audible?
Yes, sir. You're audible, sir.
Thank you, Dheeraj. Thank you very much. I mean, I thank Intus for sort of organizing this sort of series, which I thought that after 30 years, I mean, when you are more near to your end than the beginning, uh, it's time you, impart some of your experience, more your failures than success with others who are going to come up in this field. Uh, to me, hematopoietic cell transplantation, as I like to call it now, is a religion or something more than a religion, you can say. I started this journey as long back as in 1991. Although my initial craze was hematology, it was my first guru in transplantation, as you can call it, was Professor Kripal Singh Chugh in PGI Chandigarh, where I did my MD medicine. He was a father of nephrology and, kidney transplantation in our country. And my interactions with him actually raised my interest in transplant immunology to a large extent. So my interest in transplantation comes from the fact that the biology behind solid organ transplantation intrigued me. And I had seen how Professor Chugh approached the whole discipline. And subsequently, when PGI Chandigarh had brilliant all departments, but did not have sort of clinical hematology discipline as such at that time. So I went to the only place where in 1993 people could go for hematology, which was Christian Medical College, Vellore. And as you know that today is the Teachers' Day, and I did not plan it to happen on a Teachers' Day, but it so happens that it is Teachers' Day today. And I get this opportunity to salute all the greats in this field who have contributed, who have taught me, who have mentored me directly or indirectly. And one such person when I went to Christian Medical College, Vellore, was Dr. David Dennison. I know that a lot of you sitting here in India today would not know about him. But in those early days, when they had restarted their transplant program after Dr. Dennison returned from US, uh, there were more failures than success. And I would see this gentleman sit in the hospital, in the wards from early morning to late at night, taking care of patients, preparing protocols, analyzing data. He was always there. And that is where I first saw his book. That is that what I considered my Bible or Gita or Quran subsequently, which is Thomas's textbook of hematopoietic cell transplantation. It was his textbook which he gave to the department. And I used to sit there every evening or night and read that book. People who do transplantation nowadays think that it is an offshoot of hematology. But what I've learned over 30 years that the diseases we treat are mostly related to hematology or oncology, for example. But this discipline has very little to do with hematology. The discipline or the biology of hematopoietic cell transplantation is pivoted on immunology, and immunology. And what you need along with that is a very solid knowledge of medicine, pharmacology, and infectious diseases, amongst the rest. You might be a brilliant hematologist in treating chronic myeloid leukemia with 5 different TKIs or CLL with many of the newer drugs. That doesn't make you a hematologist. That does not make you a transplanter. So saying that, when I came back to India in 2010, I started doing a very different sort of transplant, as many of you would know, which is a haploidentical transplantation. And I had only two students in my life. In my entire 30 years career, I had only two students who I mention of or who I talk about. One is now what you people refer to as Professor Pankaj Malhotra, who is head of hematology in PGI EMEA Chandigarh. So when I started the department of clinical hematology from being a part of medicine, as something to stand on its own, Pankaj was there as a junior and then a senior resident. And his keenness to learn, his keenness to participate, and he was always there with me, whether it was patient care, whether it was analyzing data, teaching me how to use a computer. Those days there were no computers, mind you, in every household. So I learned a lot of how to use a keypad from him. And subsequently, when I left PGI Chandigarh, he became the assistant professor over there, and subsequently he heads the department now. And surprisingly, he still remembers me. And the other person who after I came back to India, the only person who could, have the sort of dedication, sincerity, and honesty which I was looking for always. Believe me, in my 14 years in the UK, almost 14 years in the UK, I did not find a single student who I could call a transplanter who would actually have a legacy of myself, which I actually inherited from a lot of other people. So a lot of people ran away when I started the transplant program at Apollo Kolkata. A lot of them are now doing DM oncology, past DM oncology, but they ran away from transplantation because the rigor of it was too much, or my intensity was too much for them. The only person who could withstand my, kharushness, as you can call it, and love the discipline, for practice the discipline with that sincerity and honesty, was Dr. Sarita Jaiswal, who still happens to be with me. That is her misfortune. You can come on the screen, you can just raise your hand and say who you are. Can you just raise a hand, because there are too many people around. Unmute your video.
I have unmuted.
Yeah.
Hello.
Yeah, yeah, yeah.
Yeah, in this auspicious day, rather, Teachers' Day, that which is celebrated as, I really thank Dr. Chakravarti, who has allowed me a 1 decade back. So to join his team and with him, yes, we has definitely moved ahead and we have really innovated many things, but still we need to shape our haploidentical transplantation in the field of in particular cases like non-malignant cases, which we are doing in our research lab. So once again, I thank Dr. Chakravarti and I'm saluting him to being my teacher.
Thank you. Yes, so that's Dr. Sarita Jaiswal, who is possibly the most dedicated doctor I've seen in my lifetime, apart from Pankaj. And if we have achieved the success we have today, it's simply because of her. I mean, myself singularly, I can impart some, bad or good wisdom, but to execute and to carry it forward, you have to have someone. And she has done it brilliantly, along with all the research that we have conducted. So thank you, Sarita, for being there. And I always maintain that the best teachers for a doctor are the patients, and I maintain it very strongly. But apart from that, I think I've learned a lot from Dr. Sarita as well, in the matter of how to conduct yourself. And there are many times that where I have slipped in terms of practice where I had made a wrong decision. She was there to correct me. So to start with, these are the three people who have immensely influenced my career in transplantation, apart from the person who I'll refer to next. The person on the right of your screen is Professor Donald Thomas, about whom you'll hear a bit, who actually made clinical transplantation possible. On the top left is Professor Hansi Kolb, who was a student of Professor Donald Thomas from Germany, who is the father of what adoptive immunotherapy as we know it now. And on the bottom of the screen is Professor Franco Aversa, who actually was instrumental in making haploidentical transplantation possible through their intense and immense body of work in the mid and the late 90s. And my guru in UK in all forms was Professor Tony O'Kill, who passed away very shortly after I had the opportunity to interact with him, barely for a year. And he was the pioneer of unrelated donor transplantation in children. And he always captures a large part of my existence in transplantation and otherwise, because of his contribution not only to this field, but to me as a person. So if we can, just go through the, how it all started, because a lot of things we take for granted right now. That, we have a conditioning, we have a graft, we have what we call a GVHD prophylaxis, we have a bundle for infection prevention and infection treatment, and what happens if you get GVHD. So it's all sort of there in front of us. But it wasn't so barely 5 decades back. And I was very, very surprised when the 50th anniversary of clinical transplantation was not celebrated in any form or shape in 2019, because that marked the 50th anniversary of allogeneic bone marrow transplantation. And in the midst of the, hue and cry with CAR T cells, everyone forgot about it. So the early part of immunology was marked by the whole concept of, everything is humoral, or everything is soluble. Everything is transmitted through serum, as one might call it. So when, say in 1949, Jacobson first did an experiment where they irradiated a mice by shielding the spleen, the bone marrow, the counts regenerated after some time. And it was thought that, okay, there are humoral factors in spleen which are contributing to it. Now, in a couple of years later, an experiment was published where spleen was not, shielded, but the cells from spleen were infused to an irradiated mouse under certain circumstances. And it was found that cells would regenerate. So based on these experiments, this was the first time. We now talk of cellular immunity or cellular immunology very casually, but it wasn't the case, as I told you, 5 decades back, where they were the first ones to suggest that regeneration of hematopoiesis in an irradiated subject is cell-mediated. And it was a huge ask. It wasn't a straightforward thing. A series of experiments over a decade or more were required to actually prove that cell-mediated reconstitution of the hematopoietic system was possible. And when Ford showed that, irradiated mice when transplanted, would have cells bearing the signature of the donor. It was the first evidence, what we now call a radiation chimera, which means that few of the cells were of the donor and few were of the recipient. So the first proof in 1956 that, look, the cells that we have transfused into the mice have stayed and they are working and they remain for a long time. So this was a journey from, say, beginning of the century to 1956. So just imagine the scale of time which it took to establish the concept of cellular reconstitution of hematopoietic system. And subsequently what happened was, sorry, did I miss that? Subsequently, what happened was several groups across the world attempted at doing clinical transplantation, and Donald Thomas was one of the first ones who tried to do so. And what he did was had two patients of very advanced leukemia. He used high-dose irradiation followed by infusion of marrow from their identical twins. And interestingly, the disease subsided. There was hematopoietic reconstitution, but within a few weeks, both the patients died of progressive leukemia. Then another very interesting thing happened at the same time in the then Yugoslavia, which is now called Serbia. There was a radiation exposure in the laboratory workers. A good dose of radiation from 2 to 4 gray, which caused the cytopenia in, I think 5 out of 6 of them. And they were flown to Paris, where George Mathey, another stalwart in this field, was trying to work out this practice of clinical transplantation. And what he did was infuse, I mean, mind you, there was no concept of, HLA typing at that time. So what he did was infused fetal liver cells or spleen cells or bone marrow cells, whatever, into them. Now, 5 of them had autologous recovery, but those cells survived long enough before they were rejected to make them survive. But progress in allogeneic transplantation was made through animal experiments between 1950 and the late 60s. And there are several names we need to remember and recollect every time we do a transplant. Von Beckham was the first one who showed that bone marrow cannot be given orally. It has to be given through intravenous route in a mice experiment, not intraperitoneally, but intravenously. A very common route of infusion in mice is intraperitoneal. So that was shown in 1956 in mice. And in 1957, almost the same time as Billingham and Brent first demonstrated that, okay, the mice who were transplanted in few weeks' time would develop what was called a runt disease or wasting syndrome, where they would lose weight, would not eat, and subsequently die within a few weeks, which we now know as graft versus host disease in humans, was shown for the first time. And Uphoff showed that, by simply giving low dose of methotrexate, that can be prevented. And in the late 50s, it was the first time that the concept of human leukocyte antigen was introduced. It was through examination of serum of pregnant women that it was first realized that there are antigens in leukocytes which were other than the ABO blood group, and our body reacts against those. So Donald Thomas, who actually got the Nobel Prize in 1990 for his work in clinical transplantation. And mind you, what many people don't know, that Medawar won a Nobel Prize in 1960 for his work in transplantation tolerance. And those who are interested can read it up because it's a fascinating read on transplantation tolerance, which happened in the 1950s. But what Donald Thomas did was, see, mice transplantation is an inbred transplantation, which means that the genetic variation amongst mice is very limited unless you genetically manipulate them to be different. So what Donald Thomas did was chose canine model, which is an outbred model, means there is a lot of genetic difference between the litter mates. One dog at a time gives rise to 10, 12 puppies. So what they did at that time was transplant marrow from one dog to the other of the litter mate. And they kept a diary or a chart that, okay, this is dog number 1, who I'm giving marrow for dog number 3, 4, 5. And then there is dog number 2 who's being infused from 6, 7, and 9, and so on and so forth. And what they realized is some is getting engrafted and some are not. They also established at the same time that you need a certain degree of radiation, because what they used at that time was a single dose of radiation. Whether it's 3 gray, whether it's 4 gray, whether it's 5 gray, how much dose do you need? So what they established was something in the range of 8 to 9 grays, what you need to irradiate a dog with to eradicate the marrow, which we now call myeloablation, and infuse the marrow. Now, certain marrows engrafted and certain didn't. So they gradually understood that there is something called a dog leukocyte antigen. And those who received grafts from dog leukocyte antigen matched litters, or the puppies, engrafted. And those who did not, they did not engraft. And what they also found was that just having a match was not enough. So it was largely the work of Rainer Staub, who was again a student of Donald Thomas, who used a control group where nothing was done other than giving a DLA matched marrow versus giving methotrexate along with DLA matched marrow. And what they found was that those who received methotrexate survived a longer time, a much longer time. And that was the first concept, mind you, of graft versus host disease prophylaxis. It's all happening in canine models over a period of 15 years, which first led to the modern era of human marrow transplantation. The first successful transplantation, allogenic transplantation, were 3 children between 68 and 69 who were transplanted for primary immunodeficiency from HLA matched siblings, and they were subsequently cured. But first transplantation for leukemia happened in 1969, and between 1969 and 71, 11 such transplants were done by Donald Thomas and his group. They subsequently, these were all end-stage leukemia, mind you. And if you just focus on the lower curve, that quite a few patients engrafted and quite a few patients survived. I mean, in those days, mind you, a 50% survival at 50 days was a huge thing. And quite a few patients survived beyond that. And 35 years later, when Donald Thomas received the Nobel Prize, one of them were alive. So subsequently, when Donald Thomas and group found that this actually works, that you give radiation and cyclophosphamide and give bone marrow from HLA matched donor, actually it works in quite a few patients. They went on to do transplantation in CR1. And early data, which was published in 1974, showed that, a large majority of these patients were alive at 200 days, which was a fascinating phenomenon at that time. So what happened subsequently was a phenomenal progress in the field of cellular transplantation, as I would like to call it. It's a cellular transplantation. And how we changed from using bone marrow to mobilized peripheral blood stem cells is another fascinating journey. How we ended up using cord blood as another source of hematopoietic stem cell is another fascinating journey. So now we have three sources of hematopoietic stem cells: the bone marrow itself, mobilized peripheral blood, and cord blood. But what happened in the early 70s, I mean, through the 70s and 80s, was that a lot of people, those who engrafted, those who were free of disease, died of something that was described at that time as interstitial pneumonia, which later on autopsy was understood to be cytomegalovirus infection and disease. Now, the cytomegalovirus infection accounted for 50% of the deaths at that time. And again, this is a beautiful tale in how understanding, diagnosis, and management of an infectious disease has changed the complete scenario of transplantation. Right now, the mortality from CMV disease is, in the worst case scenario, less than 5% of patients who go on to reactivate CMV developed by CMV disease if they're properly monitored and treated, and more than 50% of those survive. And compare this with what was happening when Donald Thomas established this discipline and struggled to keep patients alive for 2 decades. So with the improved treatment of CMV and new sources of graft, the scenario for allogeneic transplantation changed completely. And the other paradigm, I mean, what I called is there have been 4 paradigms which shifted in the field of transplantation. As you know, a paradigm shift is a change or a movement in our thought process from one block to the other. The first shift was when Donald Thomas, through a series of canine experiments, established that you need HLA matching to achieve engraftment. And you have to give something as GVHD prophylaxis for the patients to survive. The second paradigm shift was understanding that in order for patients to survive, you have to take care of a whole host of viral reactivations, the primary of which was cytomegalovirus. And subsequently, Epstein-Barr virus was recognized as a major nuisance and taken care of, and adenovirus, which took a longer time. And I'll come to it at some subsequent stage if people are interested in the course of our tutorials. But a major paradigm shift was in the mid-90s. Until that time, what we all thought, believed, and was staunchly entrenched in our transplant education was that we need to ablate the marrow. We need to give high dose of chemotherapy and radiotherapy to enable the donor marrow to engraft. And that resulted in 2 things. One is it resulted in a constant transplant-related mortality due to regimen-related toxicity, whether it's busulfan, whether it's cyclophosphamide, whether it's TBI, constant TRM, just because of regimen-related toxicity in the range of 15 to 20%. And especially when we were going to transplant older people. And to a large extent in the sort of early 90s, it was believed that if you're going to use those protocols in people above the age of 60, it's going to be detrimental. Now, there were 2 people who worked simultaneously in animal models. One was Shimon Slavin, and the other was Megan Sykes. They both, in their own ways in Israel and US, established in animal models, or largely mice models, that you actually don't need to ablate a bone marrow for donor cells to engraft. If you immunosuppress them sufficiently for long enough, you can actually engraft donor cells without ablating the marrow. And this gave rise to the concept of reduced intensity or non-myeloablative transplantation. This was first shown in clinic by Shimon Slavin from Israel in, I think, 20 odd patients where he used half dose of busulfan with fludarabine, showing excellent results. Now, I happened to be there in the UK when this paradigm shift had started. And I was fortunate enough to be a part of this paradigm shift and contributing to it effectively. And now we know that non-myeloablative conditioning as well as reduced intensity conditioning being subject by itself is an established way of doing transplantation. But what I showed you earlier was a photograph of Hansi Kohl, who is, again, one of my gurus in transplantation, not direct. I am Ekalavya and they are Dronacharya for me, both Donald Thomas as well as Hansi Kohl. Although I had many interactions with Hansi Kohl during my stay in the UK, personally and over other forms of communication, I never had the fortune to interact with Donald Thomas. But what I learned from Hansi Kohl was fascinating, that adoptive immunotherapy is the crux of allogeneic transplantation for leukemia, especially when you're doing high-risk diseases. And that conviction, which came out of my interactions with him, helped me in establishing the adoptive immunotherapy protocol for haploidentical transplantation, along with Dr. Sarita, which is now widely published. We have now over 20 publications in this field. And I owe it to, a huge extent to Hansi Kohl, who first pioneered the use of donor lymphocyte infusion. And his canine experiments which actually taught me how to use DLI other than just giving some lymphocytes from the donor when a patient is relapsing or relapsed. So apart from these 4 paradigm shifts, the final paradigm shift is something that is a pivot on which Dr. Sarita and I are standing today, and for which we owe this completely to this gentleman at the top, Professor Franco Agosa. So when I was in the UK in the sort of late 90s, came out the paper in NEJM where it was called the partially mismatched family donor transplantation can improve the outcome in high-risk leukemia. I still remember it, by heart, the name of that paper, because these are the events that changed my professional life and career. And it was so fascinating again, it will be a different discussion by itself, but it was so fascinating. I touched base with this gentleman. And he invited me to 2 consecutive haploidentical workshops, which took place in 1999 and 2000, led by the Perugia group, who pioneered haploidentical transplantation as successful mode of transplant. So from 1960s, where we believed that, you have to have a HLA match to have a successful transplantation. And you have to have myeloablation to have successful engraftment. We have now moved in the 90s to a situation where we can achieve engraftment without myeloablation and where we could do transplantation without having a full HLA match. So this is the journey which I had and which is up to the 90s that I'll stop over here. We will take it forward through the various sessions, and we are happy to sort of take requests. as uh, would be made by peer students as to what they want to be talked about, what they want to discuss. Because what we want, Dr. Sarita and myself, that we want people to discuss. What I find a very worrying trend across the country is that people pass their DM in hematology or oncology, and they become uh, they become transplanters after that in individual centers, private hospitals. 30 years later, I can promise. 30 years later, I can promise I know very little about this field. I'm still struggling, and I'm just narrating my journey. The journey has more failures than success, and I'm here to share the failures more than the successes. And I think people learn from their failures, so the next generation will have to learn from our failures. Donald Thomas learned from failures of George Mathey, and Frederick Applebaum learned from failures of Donald Thomas, and so it went. I haven't named another great person who I thought I would name on this session on haploidentical transplantation, but this wouldn't be complete without it. That a lot of you are talking about PTCY, and you think that it's something that's so easy to do. But George Santos was the one who, as long back as in the late 60s and early 70s, had floated this concept. The transplanters then were not brave enough to take it forward, but it was Richard Jones and his team, his students from Johns Hopkins, who later, through again a series of animal experiments, established the veracity of the concept that post-transplantation cyclophosphamide can be used. So this discipline stands on great contributions from some, phenomenal people who have dedicated their life for this discipline. And the purpose of talking today was to give a feeling about, the journey. The journey for me was from 1990, but people who have been there before have seen what has happened before, and how diligently, how honestly these people have worked to make it a success today. So it hurts me when I see today that in the name of CAR T-cell transplantation, people say that cellular therapy has emerged. My dear friends, cellular therapy emerged as long back as in 1960, because the first form of cellular therapy is allogenic hematopoietic transplantation. And the pioneers of this are not today's CAR T cell makers who are sitting in a lab and engineering T cells. Sorry, it started 50 years back, and it's still the most effective and strongest form of immunotherapy known in human history. So I would salute those great men, including my teacher, Tony O'Kill, who is no longer there, and many others who have contributed in this journey. And I hope and expect that some of this would help others to shape their careers as well, beyond just doing transplant, trying to love the discipline, trying to understand the discipline, trying to improve the discipline, and most importantly, trying to innovate in a scientific manner. Thank you everyone for your patient listening.